All right, welcome back. I'm very pleased right now to have a presentation on opportunities for physicians in the disability insurance field, which is an excellent field. I'm very much looking forward to this talk. And we really have a thought leader with us today, Dr. David Berube. Dr. Berube has absolutely vast experience in disability insurance and disability reviews. He's a former chief medical officer of both Lincoln Financial and Liberty Mutual, and he was a national medical director at Aetna, and now he runs his own shop, which is Group Health MD, which you can see on the screen right here today. Dr. Berube is also a clinical professor at both Yale and UConn. He completed his occupational and environmental medicine fellowship at Yale, earned his MD at the University of Vermont, go Catamounts, and his BA at Wesleyan. So let's have a welcome, Dr. Berube. Thanks for coming.
Well, thank you, Jim. Thank you for inviting me, and also thank you to the SEEK organization, and thank you also for the audience. It's a great opportunity to meet with you today and to hopefully give you some clinical pearls. Congratulations on considering some additional opportunities in the medical field, and hopefully with today's presentation, you get some insight on what's going on in the disability insurance arena. Yeah, as Jim said, I recently started my own consulting company. One of the things I learned is you always want to try to get a tagline to describe kind of the purpose and your mission. And getting employees' lives back on track is the one that I think keeps me interested and excited about what I do. I'm going to put my professor hat on now in the next several slides. And Jim, if you want to ask me questions during the presentation, feel free as well. I want to make sure that if something comes to mind, we can address it quickly. And also, for the audience, you'll see on the slide in the bottom, I do have my email. Feel free to contact me directly as well. There is a delay. Sorry, but there we go. Okay, little delay in moving the slides. So what are we going to cover today? So there's basically 5 things. I want to go over, after a brief primer on disability medicine and insurance medicine, we're going to go over a review of the full-time, part-time, and contract opportunities. We'll talk about some of the day-to-day activities that you would be involved in with these positions. I'll give you some insight on what keeps me excited, what I love about this type of industry and the roles that are in it. And I'll talk a little bit about some of the opportunities. And one of the key things as you decide what your passion is also is figuring out how to get involved, whether it's through networking, if you already know people, or if you don't know individuals. So I'll talk a little bit about that. There'll be time at the end for some questions. So brief primer on disability insurance. If you're not too familiar with it, this will be very helpful, I think. You'll see under the blue line, there are some bullets which describe the various types of disability insurance. At a high level, disability insurance is a payroll replacement. The requirement is that an individual has to have a medical condition that would preclude them from performing a specific job or occupational function, and that's key. An example might simply be paid sick leave, right? So someone has a brief illness, maybe for a day or so, and they typically may call in sick. In some organizations, they may need a doctor's note. And those types of benefits are probably amongst the most common that are used on a frequency basis. Then you have short-term disability, where someone may have an illness for perhaps up to 6 months, a condition that requires them to not use a leg, not use an arm, and so on. The most common type of situation where short-term disability is going to be pregnancy, which we'll talk about in a little bit, that and the other types of conditions. And then you may have a long-term disability situation where someone has an illness or injury for longer than 12 months. And you'll see on the bottom some descriptions of the different types of parameters for benefit coverage. These types of insurance coverages do not cover the medical treatment. Now, with workers' compensation disability, there will be coverage for both the insurance for medical treatment as well as for the payroll. With disability alone, not work-related conditions, the medical treatment is not covered. Moving to the long-term disability, which I indicated, typically it may be a condition for 12 months or longer, usually to the age of 65. What happens when you transition from short-term to long-term disability? The requirements change as far as what you're unable to do. The short-term disability period will cover you if you're not able to perform activities in your job description, so the specific job tasks. In long-term disability, they look at the occupational tasks. The best way I describe that might be with the job of cashier. In the national economy, there are lots of different types of cashier requirements. And some organizations, like a small store, say a gas station, where someone's just behind the counter, someone may be required to lift no more than, say, 10 or 15 pounds. But if you work in a hardware store, you might be required to lift 100 pounds. In the national economy assessment for long-term disability, they determine sort of what the average is for all the jobs of cashiers. And that lifting requirement, for example, may be determined to be 30 pounds. And so in that setting, someone who works in a hardware store, for example, may be entitled to a benefit if they can't lift their 100 pounds. But someone in another setting where the requirement might be 30 pounds may not be entitled to their benefit because they can perform those tasks. And typically, the benefits will go to retirement age. We're sort of at that period now, right, where with the retirement generation, for Social Security, it's typically 65, but going to 67, transitioning at this time with depending when you were born. I mentioned that pregnancy is the most common short-term disability claim based upon the frequency and the number of days where individuals, are out of work with restrictions. Pregnancy is one of the few conditions where the medical necessity for restrictions and the duration is based upon policy. Most companies will have a benefit that authorizes 6 weeks for vaginal delivery and 8 weeks for cesarean delivery. That said, in many settings, there may be individuals who do not need to be, quote, physically restricted for 6 or 8 weeks. They might recover sooner. But the standard in the United States is for the 6 weeks and 8 weeks, as I indicated. From the perspective of other types of conditions, for example, musculoskeletal conditions are going to be generally the most frequent after pregnancy, followed by the ones that you'll see that you see on the screen here. And those conditions require an assessment for medical necessity. So, for example, if someone has a sprain of an ankle and the provider indicates, and with medical science and just biology, that there would be a risk if someone put a certain amount of weight, certain amount of time during a day or hour, et cetera, then the medical necessity may be demonstrated, and they would have a restriction for 2 days, 5 days, a week, et cetera, based upon that medical condition. We do see some changes in the incidence of these various conditions depending upon the type of industry, and also the events that are going on a world level. During the pandemic, for example, infections, which you see is typically going to be number 12 from a frequency perspective, and respiratory conditions actually move to the top. And that's something that you'll see depending upon regional issues and also, as I indicated, the types of industries that people are working in. So One of the things that the disability assessments for peer reviews requires is to assist the individuals who are processing the benefits understand what's going on with the medical records. They typically are going to be individuals who are college educated, but they may not have a lot of medical training. And some do, but typically they may not. So what they're going to do is ask you to explain to them what's going on clinically. And the most important question is, what are the restrictions? Are they reasonably supported? If so, why? What is the rationale? What's the start date for those restrictions? And at which time uh, should they be reassessed? So, for example, as I indicated, maybe a sprained ankle. If someone has a severe ankle sprain and they're restricted from activities such as standing and walking, climbing ladders, all those things that may be reasonable to restrict someone from. At what time would that restriction start? Usually it's going to be on a date of injury. And let's say that it would be reasonable that they have a reevaluation by the provider in 2 weeks, 10 days. That would be the time frame that the peer reviewer would indicate it'd be reasonable to have a reassessment, and so on. One of the pearls might be to indicate that and then to have a description of what may be considered if new records are obtained, at that time frames. To prevent the need, for example, for that claim manager to refer it back to you to just review records again. So, for example, if physical exam at that time shows complete recovery, or something similar to that effect, then restrictions would no longer be supported. Or if at that time there's continued swelling, there's continued evidence of pain and limitation of range of motion of the joint, then an additional 2 weeks of those restrictions may be reasonably supported. So giving that individual an idea of the things to consider so they can then go ahead and make their benefit determinations. As I indicated, the restrictions are going to be the most critical thing that you can describe for them in a peer review. And what I want to do is just go over some of the important factors that need to be addressed when you review medical records for evidence of what restrictions may be reasonably supported. So first and foremost, restrictions are not based upon a diagnosis alone. Example there may be if the diagnosis is hypertension. The diagnosis of hypertension does not give you any idea if the hypertension is well treated, well managed, or if it's out of control. And accordingly, one would need to have an understanding of what the standard of care would be for evaluating a condition and looking for reasonable examination findings, reasonable follow-up, treatment parameters to determine what is reasonable for assessing and determining what the restrictions should be. They're also not based upon the opinion alone of a treating provider. For example, if a doc says the diagnosis is hypertension, no work, that indicates that there is clinical evidence that a condition may be present and that a provider has opined on what the restrictions should be. However, evidence-based medicine principles should be in the record, which provide the rationale for the opinion. If it turns out in the blood pressure hypertension example that the diagnosis of hypertension and that treatment has occurred and the parameters are now normal, and there are no other associated clinical issues that are going on of concern, in that setting, a recommendation of no work would not necessarily be clinically supported. And then what the peer reviewer would need to typically do is describe a rationale of what, if it became available in the records, and information provided, may be further useful to assess that. I don't want to get into sort of a lot of, if then sort of scenarios, because scenarios may differ. But that's just a high level example of the type of situation which you may find yourself in reviewing a record and finding an issue which is not necessarily fully internally consistent and contained, where you get information that's conflicting, and so on. The another thing to think about is that a self-report that an individual may have if they are unable to perform a task based upon an individual's feeling, and it may, be a situation where they have pain, or they may have a fear of, say, standing on a sprained ankle, etc. That alone is not sufficient. The records would need typically a clinical assessment by an appropriately qualified treating provider. I think the self-report of an individual is very important, but the basis for a restriction is the medical necessity for a restriction, typically because there may be harm or further injury if that task would be performed. And an individual who has that condition themselves is not going to be qualified to evaluate themselves and write their own restrictions, for example. One of the key things that physicians who get into this field of work often ask me is, well, who makes the benefit decisions? And the answer to that is not physicians. The insurance benefits, the payroll, insurance is typically going to, in this setting of disability, be payroll. That payroll benefit is something that the insurance company decides. Their claim managers, their administrators will decide. The basis for their decision is going to be on the policy rules, the language, the agreements that are in place between that claimant and that carrier. As a peer review physician, you have no relationship and typically no direct understanding with those policies and all those benefit determinations. So it's important to avoid language which may be suggestive that you are making a benefit determination. So, for example, it's not reasonable for you to make statements such as the claimant is disabled and entitled to benefits from carrier X, Y, or Z. Your role is to provide a medical rationale to explain the answers to the questions that are posed to you, which may include what are the reasonably supported restrictions from start date A and start date B, etc. And then the insurance carrier staff will review that and then determine if, with those restrictions, their essential job requirements may not be able to be fulfilled, and then determine based on that what their entitlements are. An example may be a situation where an individual believes they have a job requirement to, say, lift 100 pounds, and they have a job restriction of maybe lifting only, say, 80 pounds. And it turns out all they really have to lift is 80 pounds. And the employer says that, yep, they can do the job at 80 pounds, and they're not then going to be entitled to a benefit, just as a high-level example. But there's lots of scenarios and so on, and the wording in your reports is the key thing that I want to caution docs on, is to stay in your lane, stay clinical. You are not the treating provider, but you certainly can review the records provided and give a clinical rationale of what is in the information that you reviewed. There are a variety of physician roles that exist, and the most prevalent one is going to be as a treating clinician. Treating clinicians engage on a regular basis with a variety of insurance carriers. We all know this, and are frequently asked to fill out forms. They're typically called attending physician statement forms, which have information that the carrier needs. What is the diagnosis? What are the restrictions? What's the start date of those restrictions? What's the end date of those restrictions? When's the next follow-up visit, et cetera, et cetera. So that's something that you may already have significant experience with in your practice. The additional roles to consider, though, may be having a role as an employee for an insurance carrier. I've had some of those roles, and in those roles, which I'll describe a little bit, they may vary from being simply an educator, reviewing medical information, speaking to treating providers, et cetera, et cetera. You may also, instead of being an employee, be an independent contractor. Many carriers have opportunities where they don't want a full-time employee, but maybe someone for only a certain number of hours a week. And then also, insurance companies may contract with vendors, companies that would provide them access to 10, 15, 20, 30, hundreds of physicians of various specialties, for example, to help them meet their needs. So those are roles that you may want to get involved in and actually provide some services to insurance companies so that they can meet their benefit issuing needs for their covered members. I want to spend a couple minutes on this slide here that some pearls on where physicians are often challenged in providing information to carriers, and a role where peer review physicians can help with that challenge. So most commonly, treating providers will say no work based upon their assessment of an individual and their condition. The no work phrase does not describe what the actual restrictions are. So if I say no work, does that give you any insight into what the medical condition is that might result in that restriction, or might that be challenging for the employer to accommodate that patient, their employee that they have, and maybe help them so they can continue to get some income while they have that condition? The pearl is to focus on a specific body part, organ, or system and write restrictions that are focused on that. And then others can decide if an accommodation can be considered, if someone can continue to work with those restrictions, et cetera, et cetera. So if it's a sprained ankle, and the restriction then focuses on restricted from standing, restricted from walking, restricted from climbing ladders, that starts to give that employer an opportunity, and also the insurance carrier an opportunity on if they're entitled to a benefit with those types of restrictions, depending upon what the job requirements are. Another thing is providing appropriate care. In most instances, docs provide appropriate care. That's what we do. The challenge, though, is demonstrating that appropriate care is being rendered in the medical records that are submitted for review. Docs are very busy. They often take cursory notes in the electronic record today. They often might have a form they just check, a bunch of checks, and based upon the standard language, the checkoff boxes are, et cetera, they may be insufficient to really demonstrate a rationale for a sound assessment being conducted, et cetera, et cetera. So I want to indicate that if you're a treating provider, it's very important to document things clearly with a strong rationale. And then if you're a peer reviewer and there are some concerns in the rationale for not being supported, one needs to really look at the whole picture and consider how to rectify those concerns. There's also, I think, a need in the last few bullets to ensure that decisions are made using evidence-based principles. So, for example, if there's a condition and a doc has an opinion on the need for restrictions that is not evidence-based, then that may also be a challenge. It's intuitively obvious with a sprained ankle, there may be restrictions on the lower extremity, but there may be a condition such as an environmental exposure, which has not been evaluated, that is not supported by evidence-based assessments, and so on. And perhaps pending an evaluation, some restrictions may be necessary, but for long periods of time, one would expect that the standard of care, the standard assessments be performed to demonstrate those types of restrictions would be reasonably supported, especially on a long-term basis. So let's talk a little bit about a chief medical officer role. And one may assume, as you're exploring these opportunities, that you're not qualified. In many cases, you may have a sound understanding of clinical medicine, understanding of your specialty, but also generally physicians are very smart, quick learners, and I would say to apply for positions if you think you have, for the most part, the basics, the basic understanding and background. And some learning can occur with many of these roles is the point that I'm making here. What do the chief medical officers and medical directors do? Well, they obviously support all of the various functions in the organization, ranging from, claim reviews and assisting claim managers to supporting sales. And you may say, well, I don't want to be a salesperson, but in my experience in doing this, I've had wonderful opportunities where I was able to engage with medical directors of some of the largest companies in the US and globally, work with them on ensuring that their workforce was receiving appropriate health insurance, pharmacy insurance, disability, life insurance, and other types of benefit plans. There may be a need to support those customers by looking at some of their data, working with the company that you're a medical director or chief medical officer for, and ensuring that the products that are offered are supporting those customers to ensure that their employees are well and healthy and getting the care that they need. So when I have the word sales and marketing, working with actuarial staff, it's looking at the whole picture and ensuring that the various individuals have a good understanding of what is needed. You also in those roles may interact with treating physicians and communities. I've given grand rounds at some local organizations and for physician clinics and hospitals to help those individuals understand also issues about various benefits that may be provided for their patients. And you also, I think, can get involved in supporting good health and good well-being. Folks returning to work can improve their health because they get income sometimes, right? And they may not get income if they're not working or better benefits and so on. And so just being out of work receiving benefits has also been demonstrated in the medical literature to result in lower financial status and associated with that lower health status. So we want to make sure that in the role of a medical director and insurance carrier, we're promoting good health with all the products that the organizations who may be supporting offer for their members. Now, as a peer review physician, you may perform actually a variety of roles, for example, such as the ones I described for a medical director, chief medical officer. The activity is not necessarily only going to be focused on claim reviews. It's possible that you may be assigned to assist with projects, looking at data and other things. So generally the description, the scope of work that you may be contracting for as a peer review physician. It can be pretty broad. The most common one, though, is going to be reviewing medical records that are provided as evidence and explaining to the benefits folks or whoever you're supporting what is going on and what the information those records mean and support. The challenge you're going to have is to write things in a report in a fashion that is going to be easily understood, clearly understood, because your report is organized in a format which the reader is going to understand. If there are multiple pages, they can go through those pages and understand the various sections. And due to the labeling in your report, and how you answer questions, it's easily organized, and you have to be very efficient and timely. As you can imagine, reviewing records can take quite a bit of time, can be very costly to pay for many, many hours of work. So you want to make sure that you are very efficient and that you have set up a process with your workflow that is going to be seen as efficient, and accordingly you're not overbilling and so on for the support that you're providing in that role. I mentioned some clinical pearls already, and on this slide what I want to do is focus on these 4 bullets mainly. As a peer reviewer, one of the goals is to be independent and to do a full and fair review. And you really want to do this in a way in which you're not going to lean towards favoring one party or the other. That's critically important. It's true that perhaps you're paid by an insurance carrier, or you're paid by a defendant attorney, et cetera, depending upon who the payer is. But that said, they do not have any benefit if you're biased. What's going to happen if you're biased, thinking that, oh, an insurance carrier wants me to help them deny claims? It can be vastly more costly if your report is inaccurate, biased, and has inappropriate information, because that's going to be discovered, and then a second opinion is going to be obtained. And then there might be a conflict of the opinions. And then they may have to get a third tiebreaker opinion. And that goes on and on. If you provide a sound, well-reasoned rationale that's unbiased from the start, the correct decisions will be made by the parties reviewing your reports, and they will be much more satisfied with the work you're providing. And then that's a way in which you can get more work. If you provide biased work, they will realize that it's more costly to get additional reviews by others, and you develop a track record, which is just not going to bring success to you in this line of work. You want to also make sure that you have a good understanding of the clinical literature and evidence-based medicine. You want to have sound principles that you can explain, and you also may want to consider non-medical information. In some instances, they may provide you video, surveillance video, where there's someone with a sprained ankle who's supposedly unable to walk, who's now walking, and then you have to have an understanding of how to assess that information, and whether or not some clinical aspects of that can be interpreted, etc. There's also a role of an independent medical examiner, and I have 2 slides here which describe some of those roles. The key differences between doing simply peer reviews versus independent medical exams are that an independent medical examiner gets to meet and speak to that individual, that claimant, but a peer reviewer does not. Also, independent medical examiners are often asked to opine on the abilities. What is an individual capable of? I don't have that checkbox for peer reviewers. And with peer reviewers, my advice would be to opine on the opposite, what they are unable to do. So what are they restricted from performing? Example I give a lot of people in these roles is if the question was, can this electrician climb a telephone pole? And if you say yes, and they climb a pole and fall, the issues may be concerning because you authorize that they were able to do something. But if you indicate that there is no medical evidence that would restrict them from performing activities such as climbing a pole, such information may be out there. It just may not be available to you, and then you haven't examined them to indicate that they are able to do something. So I think it's much better to look at the inabilities to do things as a peer reviewer. But as a treating provider or IME provider, because you performed a hands-on assessment, then I think it's much easier for you to be comfortable documenting abilities and capacity as such. Another thing with independent medical examiners, they're often asked in a workers' comp setting to opine on the impairment ratings. And peer reviewers typically are not. Typically, peer reviewers are doing disability reviews. You can do workers' comp reviews as a peer reviewer and may be asked to opine on impairment ratings, but the frequency of that is much less. And also, both IME docs and peer reviewers may opine on the medical necessity for treatment, but as far as authorizing of that treatment, because peer reviewer is not necessarily an examining or considered a treating provider, they typically will not perform utilization review activity. So why do I find this stimulating and rewarding from the perspective of a clinical focused activity? A broad range of medical knowledge is required, and one has the ability to review treatment and clinical issues across, typically if it's US-based work, within all 50 states in all regions. And it's very interesting to see records, for example, from one region where they may have just implemented new technologies that are not available in the region that you are practicing in, for example, and able to see, what's going on. If you are reviewing for a boards exam, and so on, you have the opportunity to review medical records on conditions that maybe are rare. But now in this role, you're seeing them maybe once a month, and so on. So you do see a larger variety of clinical issues in doing this work as well. You have an opportunity to teach, which I'm pretty passionate about, and also to manage a clinical program and assist organizations in understanding what's going on. An example there may be looking at a customer or client's data and helping them understand where they have some opportunities to optimize the medical benefits or optimize the disability benefits, or potentially implement some safety changes with new safety equipment where individuals are working and perhaps getting injured, because you can look at large data sets and see the frequencies and incidences and have those understanding. So I think that, from my perspective, that's pretty enjoyable work by helping organizations to actually reduce injuries and illness in some settings. So a little bit about some of the contract opportunities and who to work for. We've covered several of these from the perspective of who to work for. Might be an insurance carrier, could be a company, a manufacturing company, a hospital. All kinds of organizations may have a need for someone to do some consulting and to do some peer review work. Qualifications. You have to be pretty qualified from the perspective of being board certified, from having a good understanding and have some qualifications within, for example, if it's disability insurance, having an understanding about insurance medicine, disability assessments, return to work issues, some of the business challenges that employers have, so that as you provide your consultative service to them, you can have some foresight in having meetings or answering questions in a way which are going to be of value to all parties. From a commitment standpoint, turnaround time is key. If there's someone out of work and there's an insurance carrier or a company and they need to provide benefits to an individual or make a decision about, say, a company replacing that individual's out with other workers, they need to know for how long, et cetera, et cetera. And they may need a very quick turnaround on the review. And if you think about someone who's getting paid on a weekly basis and they can't live without a paycheck in 1 week, missing one check, and they ask you and you commit to reviewing those records within, say, 5 days or 7 days, and you don't, then there's going to be someone who, if they're entitled to a benefit they can't get because the review's not there, could be indirectly, challenged and not being able to meet their bills, et cetera, et cetera. That will be a mark on your relationship with that organization because you didn't help them meet the needs of one of their customers. And you may not get any more work. So make sure that you are committed with any of the activity that you take on. Specialties in demand. What I've been talking about is mainly the adult medical specialties. In the workforce, there's really no children, right? So pediatrics would be the key one that's not used. Radiology is not used very frequently because there needs to be assessment of work restrictions. Radiology may be needed if there's going to be an interpretation of, say, some films and studies, or maybe some, if it's an oncology case, some of the treatment. But that would be extremely rare. Dermatology would typically be covered by internal medicine and family medicine, but there is a rare need for dermatologists. But the standard ones are going to be the most common conditions, musculoskeletal in nature, so physical medicine, rehabilitation, orthopedic surgery, rheumatology, the musculoskeletal specialties, including neurology, followed by the general medical specialties, and also mental health is another specialty which there's a great need for as well. As far as income goes, there is a range, and I think one has to look at what the service risk is. So, for example, legal work typically pays more because there's a greater risk as far as getting deposed, getting involved, and having to take periods of time off if there's court cases and stuff. I mean, from that perspective of risk with your commitment and schedule versus other types of activities, which perhaps can be done over a 14-day period in the evenings, weekends, and so less of a risk for your schedule to be interrupted from that perspective. There are a larger number of situations now where it's fee for service versus hourly rate paid. I think fee for service can be challenging because the complexity of the case that you are being asked to review often is not well defined. The number of pages that are being referred to you to review does not necessarily always reflect the complexity. The complexity of a claim may also be described by the number of diagnoses, the number of questions, the number of treating providers, if you're asked to call a treating provider. So if one has a fee-for-service-based arrangement, I think defining the complexity of the cases and having a fee schedule accordingly would be advised, from that perspective. And contract details. So my advice would be to always get an attorney or someone with experience in looking at contracts. You generally are not going to be an employee of the organization, but need to understand what your role would be as an independent contractor. And there are a variety of parameters in contracts. In some instances, the organization may indemnify you, cover the liability that you may have in doing this type of work. If it doesn't involve treatment, then it's going to be covered by errors and omissions type of insurance. Cyber insurance, cybersecurity insurance is also a new one. Most of this work is done in electronic fashion using web-based access. And as a result, many of the organizations do require that the peer reviewers have cyber insurance. And in some cases, they may provide that type of coverage for you. So how to get involved? One of the key tools, I think, to involve is just networking and demonstrating that you have the right credentials and experience. In most cases, you need at least a minimum of 5 years of clinical practice experience. And then things like board certification, being academically based, demonstrating that you have the ability to write well-written reports, and demonstrating you are able to meet their needs from a commitment perspective. Availability during your week, during certain hours may be needed to meet with individuals, or maybe blocking out a whole day or 2 half days a week. But networking with peers, I think, is the best way to identify these opportunities. And also understanding who's local to you. Collaborating with business people. Well, if you're a physical medicine and rehabilitation doc, maybe the business people you interact with is going to be a professional football team, or a high school football team or a college football team. And depending upon, if this is the coach, some of their staff. But from my perspective, if they're getting paid to work and not paid to work, there's always going to be a need for opinions when there's injuries and a need for restrictions from performing certain activities. You also may want to interact and collaborate with individuals in various business organizations that need docs. So DMEC, the Disability Management Employer Coalition, or Integrated Benefits Institute, there's several organizations that have a collective meetings similar to, maybe your specialty society meetings. But in their organizations, they do have medical content that's needed to be explained and so on, and maybe you can even give a presentation in one of those meetings. Don't avoid or feel embarrassed about cold calling, emailing, introducing yourself. If you have a company in your region where you live and a lot of patients work at, call them up and see if you can get a tour, if you can meet with some staff and explain that you're treating a lot of their employees and so on. And many docs in this line of work get consultative roles with those organizations because they went and met with them. And then when they have some needs or questions, they go ahead and they'll call you because they've already met with you. And sort of these last several slides, I wanted to give you a listing of resources that are available for you to learn. So you can attend meetings such as at SEEK. This organization, as you know, has several types of training opportunities. Also, the various specialty society, for example, the American College of Occupational Environmental Medicine, the American Board of Independent Medical Examiners, and also various references. One in particular, I have no vetting or association with them. Is the OEM Press. I have their link here, but there's lots of organizations, that have a variety of books. But this particular one is dedicated to supporting the needs of physicians who do peer review independent medical exams and are involved in the occupational environmental medicine arena. I also have on the slide some links to various articles which are available, which have some descriptive information about not only performing independent medical exams, the peer reviews. There are some texts, for example, the Gold Book reviewing evaluating mental health disability in the workplace is used and referenced in many settings when there's peer review concerns in mental health. And also, there's a variety of publications by the American Medical Association and articles in family practice journals, et cetera, that may be helpful for you to review. So you can review those as well. And that's the essence of the overview that I have. So Jim, you didn't interrupt me. I don't know that I I gave some pauses, but I hope you took some notes. And if you have any questions, I'm available now, and we have some time to answer them.
Thank you so much, Doctor. So, I didn't want to interrupt you because I didn't know what you were going to say, and you might have already planned on answering my question. So that's why I keep them to the end.
Sure.
That is
Yep.
the madness in my method. Let's talk about peer-to-peers, where the disability reviewer has to talk to the treating physician.
Yes.
How often do you think that's required on a percentage basis? I know it's hard to generalize.
Yeah. So I think the more complex a claim is, it's required more. Um, Typically, it's going to be on the order of about 30% in my experience, where a peer reviewer will look at a case. There'll be a need for some clarification of some information, maybe some discrepant interpretation of information. And you as a peer reviewer may feel then, I should pick up the phone perhaps and get some clarification. Many docs, I think, in this sort of line of work feel that's challenging, or they're not interested in doing that. But I think there's huge value. There are a number of cases I've been involved in where I've called the docs. I learned that me as a peer reviewer, maybe I didn't have all the information, right? So that's going to be one scenario. The carrier may do their best job in getting the information from their claimant, sending it to you, and then you're looking at the record and say, well, there's something missing here, perhaps, or I don't understand why the doc is coming up with the opposite opinion than what I'm getting. Are we looking at the same things? That's been extremely helpful. In addition, there are situations where the treating provider may not have all the information, right? Many patients are treated by multiple providers. They may have their information, but they may not have others' information. Me as a peer reviewer, if I have more information than the doc, that may be a reason why we have discrepant opinions. So engaging in a conversation with that provider can also help identify that. And then a solution may be asking the carrier if they can share the information they have with that provider. Critical to that request is ensuring there's an appropriate and current release of information form on file. What we don't want to do is get into situations where we violate HIPAA. There may be a restriction on speaking with treating providers by a claimant's attorney, for example, or a claimant may have just said, no, I want my privacy. I don't want anyone speaking to my docs. So that's also very important to consider. But I would say about a third of the time. And then if you're not able to speak to a treating provider, one of the pearls is to determine what questions you would have asked them, and to share that information with the claims manager that you're answering the questions for, so they can decide if they want to send a letter. And sometimes they'll ask you as a peer reviewer to send a letter to that treating provider.
Thank you very much, Doctor. Now, let's take the flip side of this. I know it's not exactly on topic, but I got to ask.
Yeah.
As you know, doctors, and as you mentioned, treating doctors are very busy. In your experience, will companies, entities, the peer review companies, the disability companies, compensate the treating doctors for doing a peer-to-peer, filling out forms, and things like that, if the doctors ask, and if so, why?
Yeah, it's a great question. So the answer is yes. They most often will.
But you got to ask.
Yeah. So I say most often will because there are a couple scenarios which maybe that's not reasonable and appropriate, right? So we don't want to say yes for all scenarios. So typically, treating providers don't have a contractual relationship with disability insurance companies, right? The treating providers may have a contractual relationship with a health carrier to provide care for the population that the health insurance carrier insures, and then there's going to be a fee schedule, contract, et cetera. But a disability carrier will typically not have a relationship with that treating provider and will send forms. For the most part, if a treating provider returns a form with an invoice and it's a reasonable amount of money they're requesting, then there is very little reason for an insurance company not to fill out, pay a bill, or for a reasonable invoice. Now, insurance companies don't necessarily want to get treating providers upset. They want them to fill out the forms. So a nominal invoice, a reasonable fee will be reimbursed. If the fee is outrageous, and I've seen some of those requests that I felt were unnecessary and too high, I think in most cases a nominal fee may be paid to that doc. I sort of pause because I've seen some of those scenarios where docs were asked to fill out one-page forms and bill thousands of dollars, to those carriers due to misunderstandings and so on. So typically, as a chief medical officer or medical director, you might pick up the phone and call that doc and say, "Why are you billing $1,000 for a one-page form that likely took you just a minute or two to fill out?" But if the docs don't ask, typically it's not going to be offered because there is no contractual obligation, as a contract doesn't exist between the two.
Thank you so much. Very, very helpful.
Yep.
Confirmed what I thought I believed.
Yep.
So let's talk about, since we're on money, let's talk about money a little bit more. I know it can vary, and vendors vary, and employers vary, but the two main things are going to be doing this work as an independent contractor, two main roles, and doing this work as an employee. And different insurance companies have different models. Can you give our audience a range of what they would get for an independent contract review, simple case, moderate case, complex case, and what they might get as like a full-time employee at an insurance company doing this work as an entry-level person?
So you mean as far as the income levels?
Yeah, people looking at this and saying, "Who?"
Yeah, sure. So with for disability insurance peer review work, I think the hourly rate range, if you think about it from an hourly rate perspective, maybe between $85 an hour and $250 or $300 an hour, depending upon the specialty and the commitment that physician gives. So looking at the $85 an hour roles, typically if a doc is less qualified, and I say less qualified because of a variety of reasons, perhaps maybe they're no longer active in clinical practice, they don't have a teaching role. Maybe they're retired and really not looking for a lot of work, so there's a very limited commitment, but they're willing to do a few things, a few educational seminars, and things like that, or just have no experience. Maybe a junior doc with very little experience, in that range, and then perhaps 200, 250 an hour. It's a subspecialty, a surgical specialty in particular, where the income is generally higher. The doc, in a sense, if they took a half day of non-clinical work, would have a reduction in their income, where if their clinical practice is bringing in, say, $400 or $500 an hour, why would someone want to, get less necessarily? And then commitment. So if a doc is blocking out, a half day, 2 days, 3 days, and they're more efficient as a result of that, right? Because the more you do, the more you understand the workflows, efficiency goes up. That can also be important to expect that there'll be perhaps a higher hourly rate. The disability peer review alone, though, is typically going to be much less than if one was doing an independent medical exam, which may be, I think depending upon the region and specialty, $400 and up, as well as legal work where you're deposed and in and out of court and stuff, which could be 600 or more an hour, as far as my understanding. So our salaries go for full-time employees. They range, if you were to look at a variety of organizations, anywhere is perhaps $150,000 to $200,000 to up to, like, say, $300,000. And then in some of those settings, there are bonus schedules that may range from 10% of that annual salary to up to 30 or more percent, depending upon the performance of the entire organization as well as the individual. So big ranges, I think, is the answer to that question.
Is there any call?
Yes. So call. Yes, absolutely. It's not as frequent as perhaps like emergency medicine or a treating practice where there's life and death situations where one needs to answer the call and address the issues. However, um, the customers, employees' lives are very important. The production that the customers have with their workforce is very important. And I will say during the pandemic, as an example, I was literally working 24/7. We had customers who had employees who needed their benefits paid, and many physician offices were not able to get the right information, and a lot of business decisions needed to be made. So there are certainly examples of call and the need to do extra work. And if you're doing a peer reviewer and your commitment is only doing a report, you need to be available to answer questions. If a benefit decision needs to be made and you have a typographical error and stuff, very infrequent. And if you do great reports, that won't be an issue. But from time to time, there is some call on a limited basis, though.
And then something that you mentioned a little bit obliquely, being clinically active.
Yes.
What is your experience with referral sources requiring clinical activity, and what is the range? What do they consider clinically active? Is it, doing it half a day a month? Is it doing 20 hours a week? Could you address that? Because I think a lot of
Yeah.
the audience
Yeah.
is interested in that, doctor.
Yeah, so there is a range. I think being clinically active and/or teaching, right? It's a matter of demonstrating you have the skill set, the credentials, the qualifications that are current and up to date to perform the activity. There are many organizations which require that someone be clinically active. Not all of them do. It depends upon, I think, the scenario of the product line they have and the benefit that's being offered, for example, for constituents in a workforce, et cetera, et cetera. But it's important to understand that medicine changes very quickly. Medical technology and advances are occurring, and it's very critical that peer reviewers be up to date and current. One can't necessarily say they're qualified to review current medical records if they haven't been practicing perhaps 20 years and have no way of being up to date. So I think if one is not clinically active, at a minimum, they need to be current with teaching, having been vetted by perhaps university organization involved with the residents, and so on. The vast majority, though, are clinically active, which is challenging in the sense that the pool of physicians who have some administrative time and are available to do peer review work is limited if they have a 5-day week practice. So typically the docs in this field will have a half day or day of administrative time, or they're doing 4, 10, 12-hour days and they have a day off, et cetera.
Is lack of current boards a showstopper? I mean, this is no boards ain't going to happen. I mean,
it can happen with no boards, but it's much more challenging. It's very challenging, and I think the scope of work will also in many settings be different. I think active board certification helps to demonstrate your current with current day medicine. Evidence-based principles, I think, are key in this line of work, and with board certification, it's a way of confirming that you can perform evidence-based work. So not impossible, but it is more challenging.
So last question, can you tell us a little bit more about your current role at Group Health MD, and how you guys, if you do, work with doctors who want to do disability reviews?
Yeah. So one of the roles that many docs have, if they're thinking about making some changes in the amount of clinical work they do, might be starting up their own consulting business. So Group Health MD is my consulting business. It's an LLC. And at this moment in time, I'm the chief medical officer. 2024, last year, is when I established this organization. And I am working with many physicians who are doing disability peer review. I am working to get them contracted, helping them understand peer review work. And also, I have some clients who are sending us work to do peer review work. So it's just one of the opportunities that came upon for me, and I'm excited about it, and it's getting very busy.
So you're doing, am I correct? You're doing coaching and you're directly hiring doctors to do peer reviews?
Yeah.
As a contractor?
Yes, right, and supporting customers who have a need for a peer review activity. Yep.
Excellent. Dr. Berube, thank you again. Excellent presentation. Excellent.
Yep, thank you, and appreciate the opportunity, and hopefully this information is helpful to those who are attending. Thank you.